My name is Jeff Holmes. I work at the Core Institute in Phoenix, Arizona. This hook plate comes in two different sizes. First size is going to be a 4-hole, which is what I have in my hand. The next is going to be a 6-hole plate. Anatomy on this, what we need to look out for with incision placement is posterior. We're going to look for our posterior tibial tendon. Anterior is going to be our neurovascular structure with our saphenous vein and saphenous nerve. We'll draw that out. We'll draw the very distal end of the medial malleolus. So neurovascular structures are going to be coming a little bit anterior, and then our posterior tibial tendon is going to be coming more posterior. So we do want to kind of separate this and do more of a midline type of an incision, and this can be a curvy or linear incision or straight. So here's where our incision will be. We're going to go just distal to the medial malleolus. So dissection will go through skin and subcutaneous tissue sharply. Again, looking out for our neurovascular structures. So once we get through our skin and subcutaneous tissue layer, we'll find our neurovascular structures, and we will reflect that superior. And then this can just be a full thickness incision down to bone. The more distal you get, you got to be careful of the deltoid ligament. We're going to sharply dissect around that. So as you'll see distally here, the deltoid ligament. Superior, you have your neurovascular structures, and inferior, you'll have your posterior tibial tendon. So you reflect the periosteum, superior and inferior. Once the dissection is complete, you'll find your fracture fragment. The fracture usually is going to be down in the distal range here, just approximately 1 to 2 centimeters above the very distal tip of the medial malleolus. Once the fracture is visualized and cleaned up, you will reduce this. You can reduce this with a point-to-point clamp, with temporary fixation with K-wires. Once the fracture is reduced and temporarily held in place, this is where we'll use our hook plate guide. It has couple spots up top for K-wire or olive wire. Here we're going to be using a K-wire. I'm going to be putting in 2 different areas of fixation just to stabilize this. Once we're secured in place, we'll use our 3-5 pilot drill distally. Next step is we will take our guide wires out, or K-wires, or the olive wires that you use. There's the tines that are going to go into those drill holes. Once you get that in the position that you like, you can confirm under X-ray once again, and then we're going to tamp this in place. Here's the tamp that we're going to use. This is going to go around the plate here, distally. And we'll secure that in place. We're going to tamp. Again, once you have good position, confirm under X-ray and make sure you're tied up against the bone. Once confirmed under X-ray, you can tack this thing back down to the bone. Again, once using a K-wire or an olive wire. Once the plate is positioned properly and fixed to the bone, we're going to eccentrically drill this through the oblong hole. Again, this can be a 2.7, 4.0, or a 3.5 screw. This is going to be non-locking, so we do get the compression we need. We're going to measure. We want to make sure this is bicortical so we get the maximum amount of compression we can. Here we'll take our olive wire out. We will add one more screw proximal. Again, we'll measure. This can be a locking or a non-locking screw. Once again, it can be a 2.7, 3.5, or a 4.0. Next step is we're going to throw a K-wire up through the most distal portion of the plate. Here we can use it freehand or from the beginning using our drill guide. This is going to be for a 4.0 cannulated screw, which again is going to be for further fixation. After the wire is placed, again, X-ray is going to be performed. Make sure that it's in adequate position. Once adequate position, we're going to use a cannulated drill. Here we'll measure the desired length for the screw. And we will place a 4.0 cannulated screw through the fracture. And then you can tighten this down by hand as needed. We'll take the K-wire back out. And then we will perform our closure and close the deep fascia over top of the plate, followed by the subcutaneous tissue and skin.